Cirrhosis is a common presentation on internal medicine. Today we'll go over the classification of cirrhosis in hopes that being able to identify and classify the disease will help us frame our understanding of it. We won't be covering the management or complications of cirrhosis. The objectives of today are to understand how to diagnose and classify cirrhosis and how to better differentiate the differences between compensated and decompensated cirrhosis. Remember that cirrhosis is a chronic disease. Pathologically, it is defined by the scarring of the liver tissue. When we have a patient with this diagnosis, we should always confirm how it was made and ensure that the patient does in fact have the disease. Secondly, we want to identify the etiology of why the patient may have cirrhosis, and this is critical because it can change the transplant eligibility and the underlying management. And finally, we want to evaluate the severity of the disease. We'll discuss a few scoring systems and as well discuss the concept of compensation of cirrhosis. In an inpatient setting, ultrasound is commonly used for the diagnosis of cirrhosis. However, it's important to recognize that this is not the preferred test. Better tests that are more commonly seen in the outpatient setting include MR elastography or ultrasound elastography, which is otherwise known as the fibroscan. They're both able to measure the stiffness of the liver as opposed to just the visual characteristics. Finally, as we alluded to before, the gold standard test to confirm the diagnosis of cirrhosis is actually a liver biopsy. This can not only confirm the diagnosis, but also help identify the etiology. However, because it is an invasive test, it's not usually used first line. Now, where does CT fall in all of this? Because it's not uncommon to incidentally find cirrhosis on a CT scan. Remember that a CT scan, similar to an ultrasound, only evaluates the visual appearance of the liver and doesn't actually measure the stiffness. The other important aspect to classifying cirrhosis is to also identify the etiology. Treatment of the underlying etiology is the only way to prevent the progression of cirrhosis. We should always consider chronic alcohol use, chronic hepatitis C infection, and non-alcoholic fatty liver disease, which are the most common causes of cirrhosis. However, at least once, every patient should have screening for other causes including autoimmune conditions, other hepatitis infections, primary sclerosing cholangitis, primary biliary cholangitis, cardiac cirrhosis, and hemochromatosis. Patients can have more than one etiology of cirrhosis, and it's important to treat every contributing risk factor. The final aspect of classifying a patient's cirrhosis is to be able to convey the severity of the disease appropriately. The use of either a scoring system or a clinical evaluation of compensation both help predict the mortality of cirrhosis. Let's review the two most common scoring systems for evaluation of cirrhosis severity. The first is the Child-Pugh score. The score consists of a numerical component which fits into a specific category of either A, B, or C. Child-Pugh C carries the worst prognosis. Although the score was initially developed to measure mortality with surgery in cirrhotic patients, it is commonly used as a surrogate marker for general prognosis. The other score you may encounter is the MELD score, which is used specifically in a transplant setting. Remember that these scores don't have to be memorized. It's more important to be able to recognize them and know when to apply them. The other aspect of evaluating severity is to look at the clinical status, and for that we discuss whether the patient is compensated or decompensated. This is important because compensated cirrhosis may carry about a 5 times risk of mortality compared to the general population, whereas decompensated cirrhosis carries up to a 10 times risk of mortality. Another way to evaluate the severity of cirrhosis is to look for clinical signs of decompensation. I use the SHAVER acronym in order to help me remember. S stands for spontaneous bacterial peritonitis, or commonly known as SBP. H stands for hepatocellular carcinoma, which we look for every 6 months on ultrasound. A stands for refractory ascites, or ascites despite optimal and maximum diuretic therapy. V stands for variceal bleeding. E stands for hepatic encephalopathy, or the inability to clear toxins. And R stands for renal injury, or hepatorenal syndrome, a common complication of late-stage cirrhosis. Now, the next time you have a patient with cirrhosis, you'll be able to think about the disease. So the next time you have a patient with the diagnosis of cirrhosis, you'll be able to think about confirming the diagnosis, then understanding the reason they have the cirrhosis, and finally be able to describe the severity in either a score format or by clinical signs of decompensation. This will be extremely important in understanding their disease.